Hi, this is Chao-Wei from the Johns Hopkins University School of Medicine and Frederick Health Hospital. Today we're going to talk about a very common dilemma when you're faced with a STEMI patient. Do you shoot the non-culprit vessel first, or do you go after the culprit vessel right away? Our case involves a previously healthy 60-year-old man who was visiting for a football game. He was having dinner with his family when he started having chest heaviness. He came up to the ER. He was hemodynamically stable, and other than complaining of some pressure in the chest, he was actually not in particular distress. The ECG showed 3 millimeters anterior ST elevations, so the Cath lab was activated and we took him to the lab. Now, our usual protocol is to inject the non-culprit vessel first, which in this case is the RCA, which you see here. So we shifted over to the auriocranial view and took our second shot of the RCA. The patient was remarkably calm and actually quite gregarious, and we were having a nice talk about his favorite football team, which happened to be a big rival to our local hometown team. And then at this point, suddenly, in the middle of a sentence, he stopped and his eyes rolled back. The nurse called out to him. He gasped for air, did not respond. We look up and we saw that he was in ventricular fibrillation. We shocked him. He stayed in VF. We started chest compressions. We shocked him again. It was refractory. He got amiodarone. He got several rounds of epinephrine. He got a total of 12 shocks. He got a lidocaine bolus. We called a code, and he was intubated. And we finally got ROSC. It took 15 minutes, but it felt like forever. And in all the commotion and the emergency intubation, one of his teeth was knocked loose and he swallowed it. We engaged the left, and not surprisingly, the culprit is a thrombotic complete occlusion of the mid-LAD. We threw a BMW wire down there and inflated a 2.5 by 50 millimeter balloon to reestablish flow. After flow was reestablished, we see a long segment of disease in the proximal to distal LAD. We placed overlapping drug-eluting stents to cover the disease. Everything advanced fairly easily. And here is the final angiographic result with the flow reestablished. We placed a balloon pump. We did not have impella at the center. He remained on high doses of 2 pressors, and we flew him out to a tertiary center for possible impella placement and further care. So this was a traumatic case for the team, and there was a lot of Monday morning quarterbacking. We typically always inject the non-culprit lesion first, and the rationale for that is that it is better to get a lay of the land before going after the culprit. But one question that everyone had was whether injecting the non-culprit RCA first actually precipitated the VF. The RCA was a little bit ectatic, and the contrast did not clear very quickly. So in the setting of an already ischemic and irritated myocardium, could that have caused the VF that became so refractory because of the occluded LAD? So would going after the culprit LAD immediately have been better in this case? Could the VF have been avoided? Of course, these are all unanswerable questions, but is there any clinical evidence out there looking at this question? In a STEMI, should you go after the culprit or non-culprit first? So there actually isn't really a lot out there on this specific question. There was a small single-center retrospective study published in 2012 involving 106 patients looking at this question. For 49 patients, they went culprit first. For 57 patients, they went non-culprit first. They looked at door-to-balloon time and also outcomes, including mortality and ejection fraction. And not surprisingly, going after the culprit first resulted in shorter door-to-balloon times. Although I am surprised at the 12-minute difference, it's hard to imagine why shooting the non-culprit lesion first would take that much longer. And as far as outcomes, there really was no difference between the two groups. Deaths, both early and late, ejection fraction, cabbage referral, or stage PCI were all the same between the two groups. So I think there are two ways of looking at this. One is that there really is not a hard benefit to going after the culprit first. There is an improvement in door-to balloon time, but that did not lead to a benefit in the hard outcomes. On the other hand, one can also argue that there is no real harm either. There was no difference in cabbage or stage PCI referrals in both groups. And of course, the big caveat for this is that this is a small and retrospective study. So here's one proposed initial approach for STEMI that seems reasonable to me. First, when you've got a STEMI, you ask yourself whether the patient is unstable. If the answer is yes, then do the culprit first, and you might even consider upstream balloon pump or impella. If the answer is no and the patient is stable, you then ask yourself whether you're dealing with an anterior STEMI. If it's an anterior STEMI, then it's reasonable to go after the culprit first. When the culprit is the LED, there is really nothing that you will find in the RCA that will change what you do. And if it's not an anterior STEMI, then it's reasonable to shoot the non-culprit first. All right, take-home messages. So for inferior or lateral STEMIs, I think it's reasonable to check the non-culprit first. For inferior STEMIs, you might think that the culprit is the RCA, but you want to make sure it's not the circ. The rule that higher ST elevations in lead 3 compared to lead 2 means RCA, well, that doesn't always work. For anterior STEMIs, I think it's reasonable to go directly for the culprit. There is really nothing in the RCA that will affect what you do. For patients who are in shock or in refractory VT or VF, it's reasonable to go after the culprit first as well. In these cases, it may actually also be reasonable to consider unloading the left ventricle with a balloon pump or impella before PCI. Thank you for watching.